learns from the perspective of each of the stakeholders who develop, deploy, and use AI systems to support clinical decisions, utilizing an ethical model of patient-centered care. His book considers the perspective of programmers, health system and health insurance leaders, clinicians, and patients when AI is used to support clinical decisions. So, Dr. Binkley, welcome, and we look forward to your presentation.
Great. Thank you, Mark. Thank you for the invitation. Thank you, Alethea, also for all of your support. I am really honored to be the inaugural speaker as part of the Health AI Hub. I'm going to go ahead and start sharing my screen. And I appreciate all of you for attending today. And those of you who sent questions in advance, I appreciate that very much. I don't know that I'll be able to answer everyone's question, but it certainly gives me a good idea of what people are thinking about and what's on your mind relative to AI and healthcare. So when I think about AI and healthcare, it's such, or when I think about AI ethics generally, or AI ethics as it applies to healthcare, it's such a broad topic. And so I'm really talking very specifically about one application of AI in healthcare, and that's AI for clinical decision making. So I spent a year at the Markla Center. It's a freestanding ethics center in Silicon Valley, learning about studying AI ethics and also working as their director of bioethics. And during that time, I was contacted by an editor at the University of California Press. And this was following 15 years of practicing liver and pancreas cancer surgery in San Francisco and running the clinical bioethics program at the hospital. And when the editor contacted me with the idea of me writing a book about AI ethics, it gave me a pause to reflect on what contribution I could make that's different and distinct from other people. And really what I thought about was my clinical practice. And just for context, if a patient who would come to see me, and let's say hypothetically, this is Mrs. O'Reilly. So Mrs. O'Reilly would come to see me with a pancreatic cancer. And one of the things that I would have to decide is whether or not Mrs. O'Reilly would be benefited by surgery. And there were times which it was very clear that she would. There were other times which it was less clear. Even in the times that by all predictive models we had that she would benefit, Mrs. O'Reilly still had an 80% chance of dying within 5 years of her cancer. So that's even with optimal surgery, chemotherapy, potentially radiation. So the patients that we said, yes, we believe you would potentially benefit from surgery, we're wrong 80% of the time. And I was always in my clinical practice trying to find better ways of predicting who would benefit and who would not benefit, because the operation itself, the recovery from the operation, the chemotherapy that would either precede or follow the operation, these all involve a huge amount of human suffering for the benefit of extended survival. And I often thought if I could just do better at making the prediction of who would benefit and who wouldn't, I could spare a lot of people suffering in the process. And so this was the context for which I thought about writing this book. So I want to start off by addressing really why bioethics is essential for understanding how AI can be used for clinical decision making. So some of you may know how the AI clinical decision support system works much better than I do. I'm coming at it from a surgeon's and an ethicist perspective, but I want to highlight some ethically relevant aspects of the model of introducing AI and a clinical decision support system into the doctor-patient relationship. So I'm going to start with how it's trained. So in the center here, you can see the model and how it's trained. So the model is trained on historic patient records. And so sometimes, hopefully, hundreds of thousands of patient records, their data will be used to train the system to make a desired prediction. In my case, let's say hypothetically, I want to use this model to predict whether or not Mrs. O'Reilly would benefit from surgery. And so the model would be trained to predict patient benefit, who would benefit from surgery and who wouldn't. And it would be trained on hundreds of thousands of patients with pancreatic cancer who had been treated surgically. And the model would find associations that would be predictive. I'm not going to know what those associations are. I would not have trained the model necessarily to look for those associations. The model would find them. So I see Mrs. O'Reilly in the clinic. I enter all of her information into the electronic medical record and the information that she's had prior to seeing me. And then the AI model would generate a prediction. Yes, you should operate on Mrs. O'Reilly. No, you should not. And so that primary prediction that I would receive would be a collaboration between me and the AI system. And I would consider the AI model's prediction. I may take into account my own opinion, and I would weigh that. I would consider that. And then as a second step in the decision making, I would go to Mrs. O'Reilly uh, with a recommendation. And so what I want to think about are those two decisions, those two decision points, the decision that the physician is going to make in collaboration with the AI model, and then how that influences the further shared decision-making model with the patient. I'm going to use the term physician here today, largely for simplicity's sake, but also in part because physician ethics are slightly different than other health profession ethics. There's a ton of overlap, but there are some distinct nuances. I'm most familiar and can speak most eloquently, I hope, about the physician ethics. But I use physician for that reason, and also because I think, at least initially, many of these models will be aimed at the physician as the user. So what are the normative expectations? So a patient enters into a relationship with a physician, and a physician has made a public profession of something. And so what is that profession? What can the patient come to expect out of the physician and that relationship? So the patient can and should expect to be respected as an autonomous individual. The patient should expect the patient and the patient should expect the physician in all that they do to prioritize the good of the patient. And every decision, every recommendation should be aimed at achieving the most good and avoiding the most harm as defined by that patient. For the Mrs. O'Reilly coming to see me, we're going to presume that the good that she wants is extended survival, and the harm that she wants is suffering and death. And so I'm going to try to optimize the good and minimize the harm. Uh, Mrs. O'Reilly would expect me to maintain confidentiality, not just that I'm not going to put it in the newspaper that she that she has pancreatic cancer, but that I'm going to safeguard all the things that she tells me about herself, uh, both in terms of dealing with other patients and more broadly with society. I'm going to be truthful and transparent with her. I'm going to explain to her why I'm making the recommendation. I'm going to explain to her what resources potentially I've used, who I've collaborated with, and I'm going to be transparent. I'm going to prioritize her. I'm not going to look at my bank account and I'm not going to say, do I need more money this month? And if I do, maybe I'll do one more surgery and it'll give me enough money to pay my bills. No, I'm going to say what is good for Mrs. O'Reilly, and I'm going to subjugate any of my desired outcomes, any of my stakes in this. There's going to be secondary to her. She's going to be absolutely the thing that I am going to focus on, the person I'm going to be focused on. And I'm going to inform her and I'm going to engage with her and I'm going to ask for her consent before moving forward. So why do all of this? Why is all of this important? So contextually, I think the primary reason why we do this, why there are these normative expectations, is so that patients can trust us. I don't have to explain to Mrs. O'Reilly that I'm going to do these things. Mrs. O'Reilly comes in with the rightful expectation that these are the things that I'm going to do because I'm a doctor, because I have make it a public profession, both by being a member of a profession, but also in taking the Hippocratic Oath. She's also going to understand that there are licensing boards. I mean, not to have a legalistic perspective, but she's going to understand that there are normative expectations of me and my behavior, particularly as it relates to her. I think ethics are important not only to foster trust, but also to manage patients' clinical uncertainty. She may come to me with pain and jaundice and all these unknown symptoms, and she's asking me to put them together, and she's going to be very uncertain. And for her to trust me, she must be able to expect these things out of me. Is also to protect the patient. There's a huge power differential between the physician and the patient. And again, the patient needs to understand that you're prioritizing them and not for your own gain or not for your own benefit. And also to guide the decision-making process. When I make a recommendation, when I consider the facts, consider potentially the prediction that the AI system has made, I am going to prioritize doing good, avoiding harm, maintaining confidence, all those things that I talked about later, first in my decision, and then secondarily when I engage with Mrs. O'Reilly in shared decision making. So who are the stakeholders? So we're thinking about introducing an AI model into a relationship, and who are the stakeholders in that relationship? So I've talked about the physician and the patient, but the AI model doesn't exist by itself. The AI model, in some ways, doesn't have complete agency. The AI model is the result of a group of people, of humans. And the first group that created the AI model, the programmers, the developers, the data scientists, they have a stake in that. And because they represent, in some ways, the AI model, I'm going to argue that they enter into that relationship also. And I also believe that the health system executives and leaders and even the payers, those who are responsible not necessarily for the development and training of the model, but for its deployment, for being an ongoing steward of that model or before deployment and even after deployment during clinical use, I believe that both groups of those people also play a role in this relationship. So I've talked about the sort of primary relationship between the patient and the physician, and the physician is collaborating with the AI model. So there are normative expectations that surround that relationship, and then you introduce the AI model into it. And I claim that those normative expectations extend to the AI model because those normative expectations build trust, they surround clinical decisions, and they are what maintain the relationship that we've talked about being primary. And then as the AI model is introduced, so are the developers, the programmers, and the health system leaders. They are sort of the people behind the model. And I also argue that these normative expectations extend to them vis-a-vis the AI model. So the AI model is entering into a relationship that has normative expectations. And because they're entering to that relationship also, those normative expectations extend to them. In this instance, at the very minimum, they have to understand what those normative expectations are in the relationship in which the model is being introduced, and be able to think about ways in which they can maintain those normative expectations. If they don't, the physician is the user. They are the power basically behind the model. The physician has to be able to assume that those things exist in order to use this model and introduce it into a relationship over which they have under which they have these normative expectations. So I'm going to move on now to thinking about what the relevant stakeholder concerns are in this. And so the four stakeholders I've mentioned, physician, patient, the programmer, developer, and the health system leader, I'm really going to focus on the physician and the patient today. The ethical concerns relevant to the programmer, the developer, and the health system leader and payer stem from this primary relationship, as I've argued. They're somewhat distinct, but really the ethical concerns relevant to them have to do with upholding these normative expectations as they introduce the AI model into the relationship. So when I think about the introduction of an AI model, and this is oftentimes what I get asked as an ethicist, what's so different about these models relative to what we use today? So I want to look at this. I want to ask, what tools do we currently use to make medical decisions, and in what ethically relevant ways is an AI model that makes clinical predictions different than how we do this today? So I'm going to start out with a clinical pathway. So this is a clinical pathway for pancreatic cancer. What's ethically relevant about this? Well, the first thing is that it is based on either retrospective or prospective research, things that have been validated, research that has been proven to be true, and not just true, but beneficial. So everything about this model is aimed at the benefit of the patient. and also aimed at doing the most good and the least amount of harm. That's the assumed balance when we look at one of these clinical pathways for pancreatic cancer. You can also see that it's been published, it's been peer reviewed. Many times these clinical pathways are published by specialty societies. Again, there's this substantive portion that is the medical science, but then there's also the ethics. Ethics guide the medical science toward doing good, avoiding harm, prioritizing the patient, all the other things that we've talked about. So how do we think about the clinical pathway versus the AI model? So let's think about clinical benefit. So as I've emphasized, these clinical pathways have been proven to be beneficial. In not every instance has the AI model been proven to be beneficial. It may have been validated to perform as it claims, but performing as it claims does not necessarily ensure that there's a clinical benefit. I think Mark is giving a talk similar to this topic, or at least talking about clinical trials relative to AI in healthcare. I think that's coming up soon. But yes, so the importance when the physician uses this model and shared decision-making with the patient, they have to be able to be sure that it's beneficial to their patient, that it's actually conferring a benefit in the same way that a clinical pathway would. Clinical reasoning, when a physician uses a clinical pathway to guide a treatment or even a diagnosis or a prognosis, they have to be able to know what the reasoning is. Why is it that we are recommending surgery to Mrs. O'Reilly rather than chemotherapy? Why are we recommending no surgery and no chemotherapy? Understanding that allows us to engage more fully with the patient and help the patient understand, and in some cases make a decision. When it comes to AI models, we don't really know why the model is making the prediction for the individual patient. We may know how the model was programmed, what data set was used, what assumptions, who validated it, but we can't tell the patient, in this instance, this is why this model made this prediction for you. And furthermore, I think that there is some hazard in assuming that we know. It may actually confirm our faulty clinical logic that we might apply to somebody else, believing that we're right and actually not having been right at all. And then finally, shared values. So when we look at a clinical pathway, we can basically presume that the same value system, the same ethics system has guided those who created the clinical pathway as guides us in our relationship with our patient. We can't really assume that. It's unknown. Whether the creators of the AI model or those who are deploying and are stewards of the AI model share the same values that we do. And I just think about this and this is neither right nor wrong, but from a health system perspective, the leader of a health system it doesn't have the obligation to prioritize that patient in front of them. They have to think about their fiduciary responsibility sometimes to their stockholders or sometimes to their boards if they're nonprofit. They have to think about the responsibility to a population of patients, whereas that physician has to think about his or her responsibility to the patient in front of them. And what is another way that we go about making clinical decisions? The use of calculators. I use this example of a surgical risk calculator because I know it well, but also because it's most relevant to the story that I'm telling about Mrs. O'Reilly. So let's say that my AI model predicts that Mrs. O'Reilly should go to surgery. And Mrs. O'Reilly asks me, well, what is my risk? What is my risk of surgery? And so I can put all of these various parameters in and be able to calculate her risk. I can put in whether she's a smoker. I can put in whether she's in renal failure, whether she's diabetic, whether she's hypertensive. All of these different factors I can put in about Mrs. O'Reilly, and it'll give me an estimate of her likelihood of having a complication, whether it be pneumonia, renal failure, or even death. So let's compare that to an AI model. So in all the previous three parameters that I've talked about relative to a clinical pathway, those hold true also for a clinical calculator. In addition, and I think this is ethically relevant, when I use a clinical calculator to predict Mrs. O'Reilly's risk of death or a complication post-operatively, I simply enter her data, and that's it. The predictor, the calculator is stagnant. Whereas when I ask or contribute her health information to an AI system, it's really given to that. We can call it shared. It's difficult to call it shared because it may be hard to get it back. And when we share something, there's the idea that we can get it back. But it's donated. I think a better model for this is donation. So the patient donates their health data, uh, potentially both for the ongoing learning of that model and or for the ongoing learning or for the training and validation and learning of other models. So that information has been donated in a way to at least to that AI model and potentially to other AI models, vis-a-vis having shared her information with the model. And that's different than using a clinical calculator. And then the third ethically relevant difference, I think, is that risk mitigation. I can say to Mrs. O'Reilly, look, Mrs. O'Reilly, if you stop smoking for a month before surgery, I will reduce your risk of having pneumonia by 50%. I can say, if we get your hypertension under control, I can reduce your risk. I can't say that. I can't change the parameters and explain to Mrs. O'Reilly how she can risk mitigate when I'm using an AI model. It is going to predict, yes, you should have surgery, or no, you shouldn't have surgery. And I'm not going to know if Mrs. O'Reilly stopped smoking, maybe she would become a surgical candidate. And then the third way in which we make decisions is collaboration with our colleagues. And so how differ between a colleague and an AI system? And I think an important way is that we can critique, question, dialogue, and discuss with a colleague, but we can't really with an AI prediction. An AI prediction also, we don't know if there's disagreement between us and the model. It's hard to know how to adjudicate that. And I think that's a very, very important factor that gets not enough consideration. And again, shared values. We can presume that when we're talking to a colleague about how we should care for a patient, then they share the same values with us, but we can't necessarily assume that with an AI model. So practically, what do we do about this? So I think as an ethicist, I'm not doing anybody any favors by saying, here are all the things that could go wrong. I think my job is really to identify the potential harms, but then to be able to come up with ethically supported ways of addressing them. So I think physician education. So I actually think that this, if we don't spend as much time and effort on building the physician or the provider end of this as we do on building the model itself, I think we're making these hugely vulnerable. I think we have to be able to let the physician know that they can trust in these models. And I think we do that by proving their clinical benefit. I think we have to be able to teach and to tell them how to use the prediction and how not to use the prediction. And I think there's some risks. I think that a prediction can affect another prediction downstream. I think an ethically relevant difference is a push versus a pull prediction. I think if I go to see Mrs. O'Reilly the morning of surgery and I log on to Epic and it pushes out a prediction to me, I may be completely unprepared for that prediction. Also, I may not know how to integrate that prediction into the care that I'm providing to Mrs. O'Reilly. It has been pushed out to me, and I haven't asked for it. Whereas if I ask, if I ask a model, should I operate on Mrs. O'Reilly or not, I'm prepared for that prediction. I know how I'm going to use that. I know how I'm going to integrate that into my decision making, even if I don't know why. And I should be able to assume that the prediction is going to be beneficial. And that's an important piece of it to weigh against my own prediction. So what kind of education should we be providing? I think it's how to avoid underuse and over-reliance. I think if we prove that these models are more beneficial, if we prove that a physician plus an AI model is more beneficial to patients than a physician alone, I think that's very ethically relevant. I think we actually can't not to use them in that setting. I think another question is, what if we prove that the AI model alone is better than the AI model and the physician? I think that's also going to be very ethically relevant. I think addressing how to resolve disagreements, particularly if I think Mrs. O'Reilly should have an operation, if I think I should take her for a Whipple, and the model predicts that I shouldn't, I really need to be able to understand why that is. And then I need to be able to know how to inform the patients of the prediction in a holistic way. I think it's probably not helpful to run in and say, look, I think you should have surgery and this AI thing says you shouldn't, or vice versa. I think we have to be able to teach clinicians how to integrate an AI prediction into their clinical decision making and their clinical reasoning. I think that the clinician, the physician, is really the point of greatest vulnerability and potentially greatest risk in the life cycle of the model. I think that we're really concentrating a lot, and rightly so, on validating, having the right data set, but we can control so much of that. We can automate it, we can validate it, we can audit it. It's very hard to control an individual in that same way. And it's hard to automate an individual, and it's hard to audit an individual. And what's the risk if it goes sideways? I think trust, patient trust, and I think at the end of the day, that's all we have. I think if we lose patient trust, we also lose the brand reputation of the health system. I think that this can cause a huge amount of physician distress, particularly if they don't know how to use the model. And I think there are probably going to be medical legal repercussions that are going to concern physicians on the front end. So I want to shift now to the patient and the patient's role in this. And again, the primary relationship, the primary collaboration is between the physician and the AI model. And then the other primary relationship is between the physician and the patient. And the physician is sort of in the middle there. So whereas I think about the physician, how does the physician make decisions? What I think about with the patient is, how does the patient trust? How do we gain the patient's trust as central to the therapeutic relationship? So who is the patient relative to this AI model? So you have the AI model, the physician, and the patient. So who's the patient relative to the model? So I think that the patient can occupy several ethically relevant roles. And each of the roles has their own sort of normative expectations. There's some overlap, but there's also some distinct. And I want to hone in on two roles that the patient plays. One is the patient is someone who receives a prediction. And the second is the patient is the source of data. Again, we can talk about data sharer or data donor. I think data donor is probably a more accurate way of thinking about this. So what do patients think about AI and the use of AI in their healthcare? So this is from the Pew Trust. It came out about a year ago. And according to this survey, 60% of Americans would be uncomfortable with their provider relying on AI and their healthcare. And there's a gradation. We can hone down on this information a bit on this survey and find out what are patients really concerned about when it comes to their provider using AI in their healthcare. So one is the security of the patient's personal health records, right? That's very important. And again, I think for most patients, it's not the fact that they have cancer that'll be on the news that night, but the fact that they can't trust that everything that they say will remain between themselves and the physician. And that's really, really important for engendering trust. The second is that the patient's personal relationship with their healthcare providers will be adversely affected. They are afraid that that's going to get worse. So what we're hearing from patients is of what I think I'm mirroring ethically is that the concern is about the relationship, and the concern is about their health information. So let's drill down on this, and let's ask the question of whether informed consent is really key here to patient trust. And so we're thinking about the patient as the prediction recipient and as the data donor. So I think we have to ask also, what is informed consent in this context? And I think it's very important for us to separate out two aspects of informed consent. So we oftentimes think of informed consent as that form that gets signed before we have a procedure, we go to the operating room. But I want to think about informed consent more broadly, with the emphasis on informing and less on the consenting process. So when we think about informed consent, what are the requirements? What do we think of? So and as a surgeon, I think of explaining to the patient my recommendation or a series of recommendations and the benefits and burdens of those, what the patient can expect, how it might affect them. And then there's the volitional portion where the patient says, and yes, I agree with you. This is what we should do. I agree with your recommendation. And I also want to ask the question, I think it's relevant here, is informing without explicit consent justified? Some would call that disclosing. rather than informing. But in the context of the use of AI in healthcare, could that be ethically justified? So let's think about informed consent relative to the patient as a prediction recipient. So the machine makes a prediction and the physician makes a recommendation. And so the physician has to take into account both the prediction that the machine has made, that the system has made, and also their collaboration with the patient and the normative expectation that surrounds that relationship. And so why is the patient making that recommendation? We would, for any other recommendation that we make to a patient, we would explain the why. We would explain why we're making it, what we took into account, what we're seeing that leads us to that recommendation. And I would say that we should probably, if we've collaborated with an AI model, we should include that as part of our thinking out loud or talking to the patient about the why behind it. I sometimes when I sense some resistance to the idea that we should be informing patients when we're using AI, particularly for clinical decisions, I ask the question, why not inform them? And I think there's some concern that patients won't want it, there'll be resistance. But I think from a consequentialist perspective, what if we've made a prediction in the background that we haven't told the patient about, that the patient would find important, and the patient later finds out about that? There would be, I think, a huge amount of mistrust. You held something back from me. You didn't tell me about something. And not only did you not tell me about it, but you were using something to make that prediction that you didn't tell me about. So I think there may be sort of a double concern there about trust. So I live just outside of New York City, and I listen to NPR every morning. And while Cornell Medical Center is advertising on NPR many times a day, its use of AI and machine learning to improve your health. And this was in the New York Times a couple of months ago. So stay amazing. That's the slogan. And I think this is this informing? Is this informing patients? This is creating, I think, and I think it's a smart way of approaching it. So when I was a resident, when I was a medical student, MRIs had just started to become popular. Every hospital was getting them. Or I can even think about a surgical robot. So when I was in practice, surgical robots became the thing. And initially, there was some skepticism and, we don't need these things. But then they were shown to be highly beneficial. And about the same time, health systems were advertising. You would drive along the freeway and you would see the surgical robot, the Da Vinci, and everybody wanted to have their surgery done by a Da Vinci. And so I think if we were to change the culture to where patients ask us, doctor, did you consult with an AI model before you recommended that I have surgery? I think our perception about disclosure, about informing would change significantly. So let's talk about how we might build trust by informing patients that they're data sharers. So I'm going to argue that the electronic medical record is really the patient's digital phenotype. So if we take a cheek swab, a buccal swab of a patient, we're going to get some squamous cells that's going to contain their DNA. And we would ask their consent. We would inform them why we're going to do this, how we're going to use it. We're going to take some of their genetic material. And the same way, I think, when we use their electronic medical record, I think that we should inform them. I think patients should know. And is there historic precedent here? So Henrietta Lacks, as some of you may know, Mrs. Lacks had surgery for a uterine cancer at Johns Hopkins University. The physician and researchers there removed some of the cells from her uterus after it was removed, and they made a cell line that's still being used today because it was cancerous. Those cells don't die, they continue to replicate. I actually use those cells in my basic science research. I know many people have, they're called HeLa cells. But nobody informed Mrs. Lacks that this had happened until much later. The case of Mr. Moore. Mr. Moore had a splenectomy at one of the hospitals owned by the University of California. The surgeon took some of Mr. Moore's spleen cells to use in his lab, didn't inform Mr. Moore. And so these are two sort of foundational cases in which we look back with some level of ethical regret that we should have informed them. And so This is just the idea of informing. In the case of Mr. Moore, the physician went on to sell those cell lines, to actually commercialize it, and that brings up a whole different set of ethical concerns. So is consent necessary? So I've talked about the importance of informing. Is consent necessary? And I think there is some precedent for saying that we're going to disclose, and then that's sufficient. And I think that one instance is when resident physicians, when somebody comes to an academic medical center and they say, I don't really want residents participating in my care, and that's just not feasible. It's not feasible not to have residents. They're built into the workflow. I think in these cases, we address patient concerns. We try to understand where their concerns are and address them. But I do think that there may be precedent for saying, we want to let you know that this is happening because we think it's important for you to know, and really separating out the informational from the volitional aspects of informed consent. So practically, how do we foster patient trust when an AI model is being used? Now, again, I think it goes back to education and information. Honestly, I think there may be a role for generative AI. The question always gets asked, well, who's going to tell? If I see Mrs. O'Reilly in my clinic and I recommend, and I use a model to recommend that to determine whether she should have surgery or not, and the model recommends surgery, who's going to tell her? Am I going to sit down and say, look, I consulted with this AI model and it's been trained, and that's not really, most physicians are not comfortable and not ready for that conversation, and could actually do poorly in that conversation. And so is this a potential role for generative AI? And I think as we disclose, as we engage with patients, we really have to have a plan for how to address their concerns. So I'm going to wrap up by talking about, I think, hopefully practically, how we actually encode bioethics into the AI lifecycle. So some basic principles. I think any health system that's going to deploy AI for clinical decision making needs to have a governance structure. And really part of that's an oversight group. And these would be a genuinely diverse group of content experts in their own fields, whether it be risk, whether it be quality, whether it be compliance, ethics, that they're content experts in their own field, but we've educated them to level set about artificial intelligence to being used for clinical decision making. I think that those groups should be genuinely diverse in terms of their discipline, in terms of their gender, in terms of religion, in terms of race and ethnicity. And I think we should include patients and families as the recipients of these predictions. I think that's very important. I think that we have to establish a systematic process in each of those areas of specialization for evaluating these models based on subject matter expertise. Again, the greater risk of patient harm, the greater scrutiny that the model deserves. We're going to have AI, we probably already do have AI models that are being used to run the centrifuge in the lab. And is that ethically, how important is that patients know that AI is being used to spin their samples? Probably much less important than if I use as a semi-autonomous robot to perform a knee arthroplasty that's run on an AI backbone intraoperatively. I think we have to, as part of that group, have a process for both intramural and extramural communication, including how to report research from that group. And a clearly defined, I think so important, a clearly defined chain of command. I'm on the Greater New York Hospital Association's AI advisory group, and a big question that comes up, particularly in academic centers, is, you may have researchers doing work over here and you have people operationalizing it over here. How do you get them to talk about, and what's the chain of command? What's the chain of command when it comes to deciding both what to disclose publicly, what to publish, and also who's going to ultimately make the decisions that the advisory board, the content experts are recommending? Who's going to decide when to pause or when to deploy a system? From the very beginning, I think it's important to define foreseen harms and benefits. What's the goal? And then also to ask the question, what level of harm is too great? A question that's being asked, I think, in a lot of sectors is, we can quantitate human harm. Should we say that that's the threshold? The system has to at least do as much or less harm than a human being, or should we actually have a higher standard? Should we actually look for a significant reduction over human harm? And then what's the level of benefit? And what level of benefit is too little? I think we oftentimes focus on harm, But in some ways, these models could have a diminishing return when it comes to benefit. And what level of benefit is too little? I think there need to be periodic audits for harm and benefit, particularly as the system is updated. And we need to have a way of detecting unforeseen harms, particularly a way of having people to be able to report harms, potential harms, for further investigation. And then I think as the system updates, particularly with a continuously learning model, we have to figure out what all it's learning, not just in terms of content, but potentially values. What values might it be learning? And so here are the cycles, and I have to thank Mark for sort of helping me think about the AI life cycle. I would have come up with many more, but certainly his work has helped me to think about it in a condensed and I think very efficient way. So here are the steps, the phases of the AI life cycle, and I want to sort of talk about what I think are the important ethical considerations. So in the exploratory phase, I think it's important to identify whether the model is operational or clinical. Potentially both, there can be overlap, but to be very honest about that so as to avoid conflicts of interest. So what we don't want to do, and I think one of the things that would rightfully engender distrust would be to push out an operational model aimed at cost savings under the guise of clinical benefit. I think both can exist, but I think we have to be clear about that. Are there, because it's hard to keep, it's hard when there are these competing priorities, it's hard to not acknowledge both. Are there equity concerns, particularly justified distribution of burdens and benefits? So for instance, if we're looking at a model that would reduce um, mortality, perinatal mortality among Black women, is ethically justified that that would focus on Black women. We don't need to have a model that's going to be applicable to everybody. But we have to have an ethically justified reason why we have an unequal distribution of burdens and benefits. Uh, Thinking about the data, the training phase, we have to think about the quality and diversity of the training data. Is it truly diverse? Is it of high quality? Does it represent the population broadly? And I could talk more about this. There's so many. This is the source of bias that we're thinking about, both in terms of the training data and also in terms of the algorithmic assumptions that's guiding the data. Does the model perform as it was programmed, and is it clinically beneficial? Also, during the deployment phase, addressing user competency and all the ways that I've talked about previously, being able to really think very clearly with users about how to address these concerns. And then also educating patients and families and other staff, not just the users, but also the other staff who may come in contact with the model. And then in terms of ongoing clinical use, the auditing process, auditing for benefits and harms, periodically reevaluating, really engaging with patient and user experience. Even if these are hugely beneficial in some way, but people hate using them, then I think that's a huge concern. And then making sure there are open lines of communication where people can voice concerns that they have about the model. That's how we're going to know early that there are potentially unintended harms and unforeseen harms. And then what is the process when harm is identified? In most cases, we have processes in our health systems for when when there's harm attributable to a human being or human beings, or even to systems. But what about when it's an AI system? I think we're much less clear about what the process is for assigning accountability in those situations. How do we communicate? And then what about extramural reporting? What are the obligations for extramural reporting? So what is the role of the ethicist in all of this? So certainly I think the academic piece is extraordinarily important. Again, thinking about the large health systems that have academic departments that may have a lot of activity in AI and AI ethics, and then also the health system itself that's trying to operationalize it. Policy and governance, as I've argued, but I think potentially the contribution of the individual ethicist is really to generate a thorough, thoughtful ethics analysis for each individual model that's being used in clinical care for clinical decision support, ensuring patient-centeredness, considering things from the perspective of stakeholders, thinking about it and trying to identify unforeseen harms, and remember that the patient harm is stakeholder harm. If a patient is harmed, then I would argue that all the stakeholders are harmed in kind. And then to not just to be able to say, we're not the ethics police. That is the last thing that I want to suggest that an ethicist should be in this setting, but rather to help generate ethically justifiable options. If there's something that we think is ethically concerning, that we would try to generate ethically justifiable options. I also don't think that the ethicist should be the decision maker. I think the ethicist should be able to generate concerns, to be able to help weigh benefits and burdens, but ultimately should not be the decision maker. So in summary, these systems, the AI clinical decision support systems, are being introduced into an already existent relationship that has historically normative expectations. I think it's so important that all the stakeholders understand and integrate these ethical concerns relevant to both the physician and to the patient. And then I think that these normative concerns, these normative expectations need to be encoded and thought about in every phase of the life cycle and continue to engage as the model is used for patient care. So I want to thank a number of people, certainly Mark and Alethea at the Health AI Partnership, my colleagues at Hackensack Meridian Health, who are a constant source of inspiration and support and thought. I want to highlight what a multidisciplinary group we have in all areas of the organization, the Center for Bioethics, and the School of Medicine, and then our predictive health work group. So thank you all very much. I will stop sharing. I'm sorry that was a little long, but I'm happy to stay if there are any questions. So thank you all very, very much.
Charles, thank you. I do have one quick question to get us started. Do you have an example? You called it an individual model ethics analysis. Do you have an example that you can share, or is there one that is publicly available that you can point the audience to, myself included? I'd love to see kind of what that looks like.
Yeah, so I can think broadly with you about how that would look. So let's take the hypothetical model of and so what I'm going to do is I'm going to basically think about ethics analysis that I've used for other models and apply them to a hypothetical. So let's talk about an AI model that I'm going to use that's going to predict whether or not Mrs. O'Reilly should have surgery for her pancreatic cancer. So as an ethicist, I'm going to think about, is this, very basic things, is this going to hold up? Is this model going to hold up for a very diverse group of patients? Is this going to be, how are we going to do the ethics audit? How are we going to think about, or how are we going to do the diversity and inclusion audit? How are we going to think about whether the model functions well for a diverse group of patients? So that's one piece of it. But I'm also going to think about, sort of the things that I've talked about. How are we going to inform Mrs. O'Reilly of this? How are we going to integrate that? That would be part of my ethics analysis. Is this going to be, are we going to do it as a best practice alert? Is it going to just pop up? There's going to be a number of options that the surgeon can click. Yes, I agree. No, I don't agree. Here are the reasons. I think, again, I don't think it's ethically supported just to be able to close the box. I think there actually has to be a clinical decision as part of that. So that would be part of an ethics analysis. Like, what would the best practice alerts look like, particularly in Epic? What is this something that would actually require consent? Like, how high risk is this? Is this model, would this model actually, would we think about it as disclosure is adequate, or should we actually, does it rise to the level of consent? So those are the sorts of considerations that I would have. I do sort of have a systematic way of going through. It depends a little bit on the model and what the decision is, but I think about it from the perspective of disclosure, consent, and then also from the physician's perspective, how do you give them information about how to integrate it, particularly if we say that it's not ethically justified just to ignore it. And again, the other the sort of the way that I would start the ethics analysis is to think about whether this is a push or pull, because I think there are extraordinarily different considerations for whether it's a push or a pull model.
It, and we may be following up with you to put some of that in the topic guide or case study. So
Yeah, absolutely.
Brian, I see you have your hand raised. And
Uh,
can you introduce yourself? Because I feel like a lot of folks here probably don't know each other.
Happy to. So I'm Brian Pilkington. I teach ethics at the Hackensack Meridian School of Medicine in Jersey, and know Dr. Binkley from Collaborations. So, Charles, this was an awesome talk. Thank you. I wanted to ask about the priority of physicians and the physician-patient relationship. I think that's right, but a little devil's advocate position. Some folks won't talk about physicians. I don't go see Dr. Binkley. I don't go see Dr. Sendak. I go to Hackensack for my surgery, or I go to Duke for my surgery. And given that a lot of AI rollout is sort of systems wide, any sort of taste gesture point us in the right direction for thinking through that kind of perspective relative to the physician priority.
Yeah, it's a great question, Brian, and I'm going to sort of even complicate or make it muddier. So I think in that case, I think those normative expectations, what the patient is saying is the normative expectations don't fit on one doctor, but they fit on a group. And I think that that group has to be willing, able, available, and willing to assume that responsibility. I think that's part of the trade-off. If you're going to create a health system and a brand, I think you have to be willing to take on that authority to be able to say that all of our providers are equally wonderful and equally great, and you'll be happy with any of them. So I think that the onus is really on the health system. But where my mind went as you were talking about is what if there's not a physician, right? What if we develop an AI model? What if we actually show that this AI model is actually better than a doctor, but better than a doctor alone, or better than a doctor in the model because the doctor is holding the model back. The doctor is disagreeing with the model. And so I mean, Forward Health, I think I told you about this, Forward Health dropped 14 pods in the United, I think it's 14 pods in different cities in the United States, where I can, as a patient, go into the pod, sit in the chair, and interact with an AI, with an AI bot. It's a generative AI model, and it will diagnose me. It'll do all sorts of things, and there's not a physician involved. So what is the ethical obligation there? And I think that's in some ways what we should be thinking about next. Are these normative concerns that we've typically ensconced in the Hippocratic Oath, and we get our white coat and we take the oath, and it's a very symbolically important moment. But what if that all goes the way of time? The other thing that I think about is that I'm giving a very specific idealized version of the doctor-patient relationship. And that is, it exists, again, it existed for me as a surgeon because I was going to take somebody's pancreas or liver out, but that doesn't exist in a lot of primary care models where, so I'm a member of One Medical, and in Manhattan, my physician is on Columbus Circle, but I can get on my phone and within 5 minutes be on a video call with a One Medical provider who doesn't really know anything about me. Now, again, the presumption is that it's going to be, I'm going to have an upper respiratory infection, or I'm going to have an itch or a rash. It's going to be very low level. They're not going to be diagnosing my pancreatic cancer. But still, the model that I'm presenting is a very idealized model. And it's one that I think is shifting. And I think we have to be thinking about how that shift is occurring. Particularly, I see Dr. Konieris on, particularly about the provision of critical care. I think that what I'm seeing is a huge trend toward automating a lot of critical care medicine that I think is going to miss something really, really important.
Thank you, Brian. There is a question in the chat, Charles, from Dr. Konieris about transparency. Is there any role for transparency in AI models to help patients and clinicians both understand and use them more effectively?
Yeah, it's a great question. I absolutely think so. The difficulty is, so if we've built the model, then we know a lot more about it, as you will know. I think the concern is always the vendor. I think it's Professor Nicholson from the University of Michigan who published a paper on this idea of an AI insurance policy. And that would be the way of assuring compliance on the part of the vendors, right? So it's a little bit of the Wild West right now. And so how would you actually, how do you incentivize vendors to be transparent? Well, you create an insurance policy that they have to buy or that they have to invest in. And I think it's a sort of a brilliant thought experiment about, how do you incentivize transparency when transparency doesn't necessarily incentivize the sorts of goals that you might have for your model or for the organization. Yeah, so Mark, you put that article in the chat. Yeah. I've sent that article to a number of people. I think it's a really interesting thought experiment.
Any final questions from the audience?
Hi there. My name's Jen Cortez. I just wanted to make kind of a big picture comment. And I think one of the ethical considerations that I'm particularly interested in is sort of how the larger healthcare community is going to be able to access these tools. I work at a federally qualified health center. We serve a large swath of northern Arizona. I don't know how we'd be able to access an ethicist, anybody with experience in the AI. Our data is messy, our IT team is limited. And so I'm really trying to figure out like how we can prepare ourselves for what's coming, because I think it is gonna create a bit of disparity with regards to those who can get care in an academic setting versus the rest of us in kind of other areas. So I just wanted to make that comment.
Jennifer, I can assure you that there is only one Charles Binkley, even. Not every large organization in Health AI Partnership has a physician ethicist involved in AI governance. So, Charles, if you want to, that's a hard question. How do we make sure that this type of expertise and perspective is accessible to sites that are going to be facing these challenges?
Yeah, it's a really hard question. It's an excellent question. I'm so glad you asked it because it's something that a lot of people are wrestling with. Again, I think about my involvement with the Greater New York Hospital Association, and that was top on their list of concerns. It's not necessarily the concern of the individual health systems, but it is for governance structures. How do we make sure that this is available? I think it has to come through the government. I think that's the only way that you're going to be able to get that kind of leverage. There has to be government initiatives that would assure equal access to these models. I don't know. I mean, I have thoughts about how that could work. I think more importantly is that we have to incentivize greater collaboration between the haves and the have-nots when it comes to healthcare. And I think that happens not just at the level of AI models, but sharing expertise. Again, I practiced a very specialized form of surgery in a tertiary center in San Francisco, California, in a place where if you wound up in Fresno, nothing against Fresno, but if you wound up as a patient without adequate health coverage in Fresno, California, you would never get any of the things that I offered. And that was heartbreaking. And who are those patients? They're typically patients who are undocumented, patients who are patients of color, patients who are unsophisticated and don't know how to navigate the system. And so I have great concern that unless we think about this more broadly, and again, I don't mean to, no negative comment toward Weill Cornell, but systems are going to I believe, use AI and machine learning and touting that as their edge in the market, particularly in a market like New York City. And if you don't have it, you're going to be at a significant disadvantage, both in terms, I think, a reputational disadvantage. Like if, it's the MRI machine, it's the Da Vinci robot. Do you have a Da Vinci robot? Do you have an MRI machine? But then we're not coming there. And then that changes your payer mix also.
And I know that we're already over on time. Jennifer, I would welcome you reaching out too with any ideas you have. We feel very privileged to work with an incredible network of sites and experts like Charles, and we're actively looking for ways to help kind of disseminate that expertise and distribute that within the network and beyond the network of sites that we work with. So that is something that we are very interested in doing better. Obviously, forums like this are one way to do that, but that reaches 30, 40 people. And we know that there's a whole lot more opportunities. So Dr. Binkley, any closing remarks? I want to respect everybody's time.
Yes.
I know that there's more questions, and we welcome folks reaching out to Dr. Binkley as well.
Yes, absolutely. Feel free to reach out. No, Mark, I certainly do appreciate the opportunity. I think this is an evolving conversation, and it'll be interesting. I'm very, very privileged to be part of the conversation.
Thank you, everybody. Have a good rest of your day.
All right. Thank you. Bye-bye.